Thank you for joining us today, and we are going to be tackling the topic, cracking the code, understanding spirometry standards, predicted value sets, and their interpretation. My name is Jamie Burgess, and I am a registered respiratory therapist, and we are excited to bring this program to you. The webinar objectives for today, we're going to be talking about spirometry standards, 2005 and 2019, what changed and why did it change? Understanding those key differences in the international spirometry standards and why they matter for our clinical practice. We're also going to talk about predicted value sets. What are they and what do they mean? Talking about the multiple reference equations that exist, how they can impact test results, and how to choose the most appropriate set. Talking about interpreting spirometry, so ATS, GOLD, LLN, NICE, all of these different interpretation guidelines, and what maybe is the best approach to support accurate clinical decisions. A few more clinical insights from spirometry. What can it tell us and what can it not tell us about a patient's respiratory health and appropriate next steps after testing? And then lastly, just emphasizing the value of spirometry. Lots of details to work through, but why is it still important and essential to improve patient care, early diagnosis, and long-term management? So we are so excited to have Karl Sylvester with us. And Karl, if you want to give a quick introduction about your background, how you're involved in the world of spirometry, just so that we can get to know you a little bit better.
Yeah, sure. So I work in Cambridge in the United Kingdom. I'm a consultant healthcare scientist. My background's in respiratory physiology. So I've been doing lung function testing for about 30 years now.
Yeah.
So a long time. From a spirometry perspective, obviously that starts with spirometry when you're learning to be a respiratory physiologist.
Right.
I've been chair of our national professional body, so the Association for Respiratory Technology and Physiology. They're the guardians within the UK of all respiratory physiology techniques and standards. And as part of that, we have a spirometry register.
Okay.
So anybody in the UK that would like to perform diagnostic spirometry needs to be on the ARTP register to be able to do it. And as part of those standards, it's about they have to complete a portfolio of evidence, they have to complete an examination, and once they complete all of those bits and pieces, they can then go onto the spirometry register, be qualified to perform quality assured diagnostic spirometry in whatever setting, community, secondary care, wherever they would like to.
Yeah, and I love that. Globally, it's different everywhere. Like you said, you all have very strict standards of who can perform spirometry, who can look at it. We know that that's a little bit different all over the globe as far as what kind of qualifications, backgrounds, training programs that you need to be able to do spirometry. So yeah, I think that's super interesting. So, spirometry standards.
Yeah.
2005 versus 2019. It was a really big gap between when the last standard was introduced and the current. What were the biggest shifts between 2005 and 2019 as far as the spirometry standards?
I guess one of the biggest ones was the introduction of a usability criteria. So in the past, tests were either acceptable or not acceptable.
Right.
But now we've got a usability criteria.
Yeah.
And I think with that, what it actually introduces is that you cannot pass or fail a spirometry test. If you don't meet the acceptability criteria, the results still might be useful for the clinician.
Right.
So potentially in the past, what you might have found is that somebody performs a spirometry test, the results come back, they haven't met acceptability, and the person performing the test thinks this isn't going to be useful for the clinician.
Right.
Or actually, there is information in there that still might, if it's bang on normal, then that's going to be useful for the clinician to know that.
Right.
If it's well below the lower limit of normal, and I guess I'm going to talk about that a little bit later on. If it's well below that lower limit of normal, then you can probably be assured that it's abnormal.
Right.
It's the grey area where then it becomes a little bit more down to clinical interpretation.
Right.
But having the ability to say these results are not acceptable, but they are usable, will really help future management of the patients for the clinical teams that have requested the test.
Yeah.
In terms of other things that they brought in as well, they brought in some grading criteria.
Yep.
So you can be graded sort of A down to U, and the U would be this is usable, but it doesn't meet the standards above. And of course, we've got different acceptability criteria around whether FEV1 and FVC are within 150 mils, whether it's within 200 mils. And the less acceptability criteria it meets, you go down the grading. As you know, that's for FEV1 and for FVC as well.
Right.
So those are probably the two main things that I think your viewers would be most interested in knowing. There are other small technical implications within the type of device and what's required from a mechanics and quality control within the device side of things. But in terms of performance of spirometry, the grading and the introduction of the usability are probably the main things that have changed between the two guidelines.
Right. And why was it important for those standards to be updated? You hit a little bit on that. Again, data is data. Before it was pass or fail, we've added that gray area where some of those numbers can still be useful. Like you said, do you think that this change really does benefit patients, those that can't do that perfect test?
Absolutely. And I think guidelines are only as useful as the day they were published.
Right.
Guidelines are based or should be based on published evidence. So between 2005 and 2019, can you imagine the number of publications that have come out about spirometry, and particularly about how the performance of spirometry and the standards introduced within spirometry have changed practice within those years.
Right.
And I think the benefit to the patients, as I'd outlined, is that you've now got better accuracy in the data for the patient. So the clinician that's requesting the test can be more assured around whether a grade A spirometry test is spot on as you'd expect it to. But as I say, having that usability, the benefits of the patient are they don't have to keep coming back to having it done because they haven't met it. And also they can get to a diagnosis quicker because you've now got a usability criteria that the clinician can use. Yeah,
absolutely. Switching topics just a little bit, talking about those predicted value sets. How do we know what is normal for you? What is normal for me? This might sound like a self-explanatory question, but why do we have so many predicted value sets? What are the main things that differentiate one from another?
Yeah. So I think probably everybody likes to create their own local population reference values. And if you look before GLI, so the Global Lung Function Initiative, you would have had pockets of these reference values all across the globe.
Right.
What that introduced, though, was some variability if people moved from place to place to place.
Right.
So I think what really helped them was the Global Lung Function Initiative coming together and developing those all-age, global reference equations that wherever you are in the world, whatever criteria you met, you fall within that particular category. And it gives you then greater confidence that the result is either normal or abnormal. And when we talk about normal or abnormal, I mentioned earlier about sort of lower limits of normal. People still use percentage of predicted.
Yes.
And it's still in some guidelines, particularly GOLD, around the use of percentage of predicted. But we know that from population statistical evidence and publications around population statistics and epidemiology, that using a percentage of predicted or a fixed cutoff ratio of 0.7 potentially falsely gives the older age population a label of having obstructive lung function.
Right.
So by using the lower limit of normal, and there's a number of other names that it can be called. So not just lower limit of normal, you might see it seen as the 5th centile.
Yeah.
You might see it seen as a Z-score of minus 1.645. They all mean the same thing.
Right.
It's just, is it below the boundary of the normal population? You do have to think that even if it's below that minus 1.645 Z-score, there is the potential that it could still be normal. But the further down that scale you go, the less and less likely it is to be normal. And I think what that also raises is the fact that spirometry is an aid to diagnosis. It doesn't give you the diagnosis.
Right.
So you have to use your clinical judgment based on the result. So I did a skills workshop yesterday, and we interpreted some of the results, and there was one that was kind of minus 1.63.
Right.
So just within the normal range. And so we had the discussion about, is that normal or is it abnormal? And by the guidance, it's normal.
Right.
But just imagine, all it needed to drop into the abnormal range was to go 0.02.
Right.
So it really is important to not treat any lung function test as the diagnosis. It just supports the clinician when they're trying to find a diagnosis.
Right. Absolutely. And choosing a specific reference set, like you said, it can affect diagnosis and patient outcomes. You mentioned GLI and kind of that was the goal. Had you seen specific instances where using those regionally specific predicted value sets was a detriment to patient outcome?
Yeah, so particularly, and I think where the GLI reference equations mainly came on was the cystic fibrosis population. So obviously cystic fibrosis in the pediatric population, they then go into the transition period in sort of adolescence and then into adults. And what the CF clinical community were finding was that patients were reaching 18 years of age and suddenly becoming worse. It's like, well, what's happening? Like, why are suddenly all of these 18-year-olds turning 19 having worse lung function? And it was a consequence of the reference ranges they were using, because they were using pediatric specific reference ranges and then moving to adult specific reference ranges, and they didn't line up.
Yeah.
So the GLI went out, retrospectively collected lots of data between the ages of 4 and 80, and we're able to then provide a single reference equation across the whole age range. Now, initially, when they published them in 2012, they did have them separated into different ethnicities, different races. But subsequently, over the last few years, clearly there's been a lot of debate and discussion about how appropriate that is. And whether there's other things other than race that might be influencing lung function that might include sort of socioeconomic status, nutritional status. And so now GLI have created the race neutral equations that are quite useful. They do slightly widen the area of normality, but it just means we're being more inclusive for the population that might need spirometry done, and being more specific, particularly around things like occupational exposures, maybe disability assessments and those kind of things, bringing more people into a level of normality that maybe in the past they would have been inadvertently given the wrong label.
Right. And I feel like we have already answered this question, but as you know, there are certain areas of the world where a certain predicted set is still mandated for either reimbursement or lab certification. In your opinion, which value set should clinicians be using? And I think you've hit on the why, but kind of any last arguments for those areas that are still very diehard on their own predicted value sets to turn to GLI?
They are the most representative of the global population that we have at this point in time. And it's similar from when we went from the 2012 to the present day race neutral. It's all about evidence coming through. Places like the European Respiratory Society Conference, the American Thoracic Society Conference, we have evidence after evidence presented all the time and published about the impact of reference equations and how they impact sort of clinical interpretation. But I think the race neutral ones that we have now are the best that we've got for now. Let's see what happens in the next few years.
Absolutely. Well, thank you for that. We're going to switch gears again just a little bit and talk about interpreting spirometry now. This is a topic that we get a lot of questions about because it can become a little overwhelming. We already, as we discussed with the predicted, we have all of these different options, and the decision for these clinicians to say, okay, now I have found which predicted value set I am going to use to determine is my patient normal or are they abnormal. Now I have all of these results. What do I do with them? We have ATS, we have GOLD guidelines, we have NICE, we have lower limits of normal, we have occupational groups like NIOSH who like to set their own rules for interpreting spirometry. Why do we have so many interpretation guidelines?
It's a very good question. Why? In an ideal world, there would just be one way of interpreting spirometry. I think these different guidelines get developed because they are thought to be specific to certain populations.
Right.
So if you think about GOLD guidelines, they're specific to diagnosing COPD.
Right.
I'm guessing the NIOSH ones are specific around occupational health.
Correct. Yeah.
So, and a lot of the time, it is very much based on consensus opinion, consensus expert opinion about whether this is correct or not. And we have to challenge, I think, the applicability of some of the interpretive strategies that have come out on these, because it is, well, they're not based on published evidence.
Right.
Whereas when you look at the latest 2022 ATS ERS interpretation strategy, within that document, there's a lot of evidence about why they're using specific criteria to interpret spirometry that I think are lacking in some of the other interpretive strategies.
Right.
So if I'm not wishing to, I don't know how to phrase it, but if we take GOLD for instance, I've already mentioned previously. At the moment, they still use a fixed cutoff of the FEV1 FVC ratio of 0.7. But we know from published evidence since 2012 that there is going to be some over-emphasis of the presence of obstructive lung disease in the older population by using that cutoff.
Right.
So we have to be very careful. But then again, I guess it comes back to the fact that the sole reliance on that as a diagnosis or an interpretation of whether that individual has COPD shouldn't just be on the spirometry outcome.
Right.
Clinicians will use it as an aid, but there should be other factors involved that the clinician will have to hand: clinical history, physical examination, maybe radiology, smoking history, family history. All of that needs to come in. The spirometry is exceptionally useful tool within that, but it's a small kink in the chain.
Right. Yeah. What factors should clinician consider when deciding which guidelines? Like you said, GOLD is specifically for COPD, lower limit of normal, ATS. Should we take in suspected diagnosis or known diagnosis when we look at, which guidelines to apply in our practice?
So I think if you're running a COPD clinic, you're going to use GOLD guidelines because those are the ones that are in. But I think that's okay, but just be mindful of the fact about this lower limit of normal.
Right.
If you've got any clinical uncertainty, using the interpretation based on the GOLD guidelines, and you think this doesn't quite meet what I think the patient is, then think about the ERS ATS and the lower limits of normal and utilize that to give you more reassurance about the outcome from the test.
Right. Yeah, I feel like our comfort level is this person is very healthy, this person is very sick.
Yeah.
It's all of that in the middle that really can kind of muddy the waters a little bit. And again, we had down the question on which guideline, do you have a strong preference one over the other? And like you said, it really comes back to where do we have evidence? Where do we have publications? Where would we, if you are just a general practitioner, not somebody who is looking at specifically COPD, specifically asthma, do you have a strong recommendation for that interpretation?
I'm going to come back to the ATS ERS 2022. When you look through that document, and I would highly encourage people to read it, just the level of evidence that they have now as to why it's not just expert consensus opinion, it's published evidence. It's there from data collected over sort of many years and within many numbers of patients. So, that's the one I would strongly encourage people to use.
Absolutely. Kind of switching gears again, looking at clinical insights for spirometry. We've talked about you can't make a diagnosis strictly on spirometry, but we also know that there are areas in the world where diagnoses are being made, drugs are being prescribed, and there's no spirometry. There is, patient questionnaires, there is, physical exam only. We know that spirometry really does need to be an important part of that diagnostic journey. So why is it important for clinicians to really understand the information that spirometry can contribute to a diagnosis?
I guess if you take the latest NICE guidance that came out around asthma, it talked about you only need a pheno to diagnose asthma, but okay, that's fine, you've diagnosed asthma, but you still need the spirometry to understand what the response is going to be to any potential therapeutic intervention.
Right.
It also allows you to grade the severity of that disease as well.
Right.
And that might impact on disease management as well, different therapies that you might give within that as well. Obviously, there's the asthma management plans that people are given as well. That will be based on the severity. You don't get that just from Pheno.
Right.
So, you know, spirometry is never going to be replaced by any other test. There are other things that might support and help spirometry.
Right.
But spirometry is going to be the cornerstone of what we're looking at in terms of diagnosis within respiratory disease for a long, long time to come.
Right. How can spirometry results impact treatment plans and then ultimately long-term outcomes for our patients?
Yeah, so being able to monitor the spirometry values in patients with disease is really important. Because you're going to need to know, one, has there been disease progression? Two, has there been any response to the treatment that you've provided? And then kind of a mix of the two, you know. If this individual has been provided with an inhaler, well, what better way to determine whether that inhaler is working or not than performing a spirometry test, looking at the FEV1, looking at the FVC, and making sure it's giving you a value that's appropriate.
Yeah, absolutely. Yeah. Like you said, what are some limitations? What can spirometry not tell us about our patient?
Yeah. So spirometry is very good at telling us whether there's an obstructive abnormality.
Okay.
Where it's less good is telling us whether there's a restrictive abnormality.
Yeah.
So even if, so how we would diagnose, or not diagnose, but how we would suspect that there was a restrictive abnormality on spirometry would be to look at the FVC. So if the FVC is low, then it would suggest that there's a restrictive lung disease.
Right.
However, you need to do other tests to look at lung volumes in another method, either through a dilutional technique or through plethysmography, but either is equally as good to look at lung volumes. So we published a paper fairly recently looking at can we use either spirometry, alveolar volume from a single breath gas transfer, or TLC from body plethysmography to say whether someone's got a restrictive disease.
Yeah.
FVC was quite poor at telling us whether there was or there wasn't a restriction.
Right.
Whereas alveolar volume from a single breath gas transfer was equally as good as total lung capacity from body plethysmography at confirming that restriction. So we don't need to have big fancy body plethysmographs within our service just to look for restriction. There's other methods that we can use to do that. Yeah,
absolutely. And then after identifying abnormal results, whether it be from spirometry, patient history, radiological results, what are the most important next steps for clinicians? Because again, we do have a lot of primary care doctors, non-specialty folks that watch our webinars to learn more about spirometry. So what are the next important steps for them when they do find something that is abnormal?
On spirometry or any of the lung function tests?
Sure, spirometry specifically, but you know, is it an immediate call to the pulmonologist? Is it an immediate, you know, kind of a drug safari? You know, what are those next steps for those clinicians?
So if you've identified an obstruction on spirometry, then the first thing would be to do a reversibility assessment.
Okay.
So you'd give an inhaler, and then you'd measure the response after they've done that using spirometry again.
Yeah.
And what we're looking for there, and again, there's a number of different guidelines associated with how you measure a response to a bronchodilator. So most people would use, at the moment, 12% and 200 mils change.
Right.
However, again, coming back to the fact that we've got published evidence now within the 2022 interpretation statement, the best method at the moment for measuring whether someone responds positively to a bronchodilator, you take your post FEV1 or FVC value, you minus your pre FEV1 or FVC value, you divide that result by your predicted FEV1 or FVC, times that by 100, and whatever result you get, if it's 10% or greater, that tells you have a positive response to the bronchodilator.
Right.
So yeah, the trouble with the 12% and the 200 mils was that there was age, sex, and size bias into the response. So males had a propensity to respond more than females.
Right.
Taller people had a propensity to respond more than shorter people.
Right.
All of those things played an impact on the response that you were getting. Whereas the 10% change is much, much better.
Right.
Again, I'm not saying it's the be all and end all, because there'll probably be more research coming out at a later date.
Right.
But that's the one that we should be using at the moment.
Right.
Beyond that, then, once you know you have a response, then it's starting them on whatever appropriate therapy is appropriate for your local area.
Right.
I'm assuming that it's probably different in the UK to other parts of the world. You know, we have quite strict criteria around what patients should be started on, what they escalate to.
Right.
So we would do that, and then thinking about once you've got that diagnosis, if it's a restrictive abnormality, that probably needs to be cared for in secondary care.
Right.
Whereas an obstructive abnormality can potentially be managed and cared for in the community.
Yeah.
A restrictive abnormality, you're probably going to want some form of radiology. Similarly, with an obstructive abnormality, you probably want to see, is there something going on radiologically that you can pick up as well? Is there any evidence of any emphysema? All of those kind of things. So therapy, radiology, and getting a good history from the patient.
Yeah. No, absolutely. And kind of brings us to our last topic, but just emphasizing again the value of spirometry. We know it's a patient-dependent test. We know it's a coach-dependent test. We know that there are all of these different aspects where we can look at spirometry that can make it sound a little scary, a little mystical sometimes, and make people a little apprehensive to perform it. But at the end of the day, doing spirometry is only going to help our patients and get them on the path that they need to be to manage their condition. So how can the use of early spirometry change the course of disease management for our patients with COPD, asthma, and other lung conditions?
Yeah, so bringing it as early as possible in the pathway is really useful. So there was a randomized control trial done out of Canada in 2024.
Okay.
And it demonstrated that you know, having spirometry earlier in the pathway got the patient to an earlier diagnosis, improved quality of life, reduced exacerbations, reduced length of stay if people needed to be admitted, reduced admissions. So there's evidence out there around bringing spirometry as early as possible into the pathway really does improve patient outcomes.
Yeah, excellent. And like you just said, I mean, there is the study that you just mentioned. The question is about, you know, do we have this concrete evidence showing that an earlier diagnosis is leading to better long-term outcomes? Any other examples that you can share on publications that are out there that kind of prove this point for us?
I think that's the main one, to be honest. Like, I mean, if you think about the level of evidence, a randomized control trial is top of the tree for the evidence. There are other published papers out there, but they're not at the level of a randomized control trial. So, and that, you know, the randomized control trial may well have pulled in other evidence from other published papers as well. But yeah, I think that 2024 paper, without sort of overstating it, was probably seminal in terms of what it meant for bringing spirometry earlier on into the pathway for patients with respiratory disease.
Yeah, absolutely. And I mean, the last question that we have is, what would you say to these clinicians who are on the fence looking to add spirometry to their practice, but they're maybe unsure, maybe they're uncomfortable, they're still in the learning kind of discovery phases of what it means? What advice would you have for these clinicians?
If you are thinking about introducing it into your pathway, I think the evidence is there for itself to say you are going to be improving the outcomes for your patients by having this test available for them. If you're concerned about being able to do it to a particular standard, I always find the best way for whatever diagnostic technique I'm using is to find people that you know are already doing it. And you know, gain their expertise and knowledge from it as well. Build up those local networks. You know, one of the other good ways of doing it is sort of generating your own kind of MDTs. So we often have kind of local groups set up where you've got very experienced people coming in with their results.
Right.
And then you've got less experience coming through. And again, there's no judgment if you don't know what the answers are.
Yeah.
You feel free to bring anything through, and you've got the advantage of having the expertise of those people being able to support you.
Right.
So I would look, as you're starting up the service, for people within your local area that you know are doing it and doing it well.
Right.
Maybe look for local training providers as well, to see if they're able to do it. Obviously, your friendly local distributor or manufacturer of lung function equipment are a good source of evidence, because they're going to know who the experts are that are doing the test as well. You know, they support those people. So bringing all of that into it as well is really going to support you in providing that service for your patients that's just going to give the best possible clinical outcome in the future. You're also going to be supporting, it's about the patient, but you're going to be supporting local healthcare economy.
Yeah.
You know, there's going to be a reduction in probably your drug spend, because you're not going to be providing needless drugs to patients that don't need it.
Right.
You're going to be identifying people earlier, so you're not going to have them entering the process later, which then will have longer term health implications as they progress through their disease.
Right.
So it's just a win-win, and if you're not doing it, why aren't you doing it?
Yeah, exactly. Well, we really appreciate you taking the time to come over and kind of tackle some of these topics that, you know, we do get frequent questions on from those primary care level physicians, and, you know, who really, again, they want to be comfortable. Obviously, they want the best outcome for their patients, but sometimes just clearing the noise makes it a little bit easier, and really talking through these topics, the how and the why, really does help them make that decision. So again, I really do appreciate the conversation, and hopefully we can get you on for another topic sometime.
Great.
That'd be great.
Thanks very much.
Thank
Thanks
you
for the invite.
so much.
Okay.